everyone. Thanks a lot for joining, and it's a pleasure to be here. So the talk is about to educate what the actual problem is in stroke we have. Just as a minor background, I'm a board-certified neurologist, was running Germany's first stroke unit in the early 90s. So stroke is my background, ultrasound is my research background, and you will hear a little bit about it. So let's start with some basics. So why stroke? Stroke is the second common cause of death worldwide. About 15 million patients or people suffer from a stroke every year globally. Here in the United States, it's about 800,000 to 900,000 every year. The most prominent stroke we see is the so-called ischemic stroke, where a blood clot is blocking a vessel, and we get into this in a second. It's one of the most costliest diseases we know. Just in the United States, the cost average is about $53 billion per year in stroke-related costs. And it's the number one cause for long-term disability, more than myocardial infarction, brain tumors, or any kind of tumor diseases we know. So that's the background. Let's talk a little bit about the pathophysiology if you're not familiar with this. So I've mentioned that the most of the strokes are so-called ischemic strokes. So what happens is that a blood clot, which might be generated in the heart, somewhere in the blood system, is now being flushed up the brain, is occluding a brain vessel, and then it's like a clogged tube in your bathroom or wherever. Means once a blockage is there, oxygen-rich blood cannot surpass, and the distributing supply area will not get oxygen to the extent it's used to. So the brain, unfortunately, is very intolerant when it comes to this situation. Brain cells, neurons are extremely sensitive when it comes to deoxygenation. So already within the first seconds, the first minutes, brain cells suffer and die irreversibly. So when we talk about stroke treatment, stroke care, we're not actually talking about what's called the core. And just to give you a quick explanation of what it means. The core is the part after cloggage has taken place. It's the part where the neurons are already dead. So we cannot recover them at all. They're gone. The penumbra is the area where cells are really, really suffocated. So it means we can't salvage them if the blockage is being removed and oxygen is being provided to the cells. The oligoma is the area where the neurons are already suffering a little bit, but they're still functioning at a lower rate, but they're still functioning. So what all is about stroke care or stroke treatment is not to salvage this red area, the core, but the penumbra. That's what it's all about. And why it is so critical, you see here, because once the blockage has occurred, it doesn't take very long to let this core dead tissue grow over time. So it means the longer we wait, the lesser chances we have to really salvage the tissue we are after, which is the penumbra. So that's the story. Just to underline what it means, and that's all scientifically proven, every minute after blockage, about 2 million brain cells die irreversibly. They're not coming back. To give you a reference of a myocardial infarction, a cardiac cell under the same conditions, no oxygen, will survive about up to 30 minutes until it dies irreversibly. Now, of course, it's a not fair competition because we have a neuron very sensitive and we have a muscle cell on the other side. But it's just give you a correlation. So this number, I would like you to keep in mind because we're coming back to it in a little bit. So let's talk about some signs of stroke, the diagnosis of stroke. So what you have is, symptoms you might be familiar with, you might have seen it, such as facial droop, weakness in an arm and a leg on one side, speech problems. All this can be signs of a stroke. And it's actually, you may have seen it. There's a recommendation by the American Heart Association, which is fast, face, arm, speech, and time. If you see changes in these three aspects, we could call 911. That's summarized under what's known as FAST. Now, stroke is a pure clinical diagnosis. It does not say anything about pathophysiology. The problem is, though, that with stroke symptoms, there comes a long, long list of differential diagnoses. So if you see these symptoms, it might be a stroke, but it could be very much something very different, like a migraine attack or a seizure. So by clinical inspection alone, it's not easy to say, yes, this is a stroke or not. And actually, in fact, if we look at the emergency departments here in the United States, the false negative stroke diagnosis rate is 9%. What does it mean? That means 9% of all strokes, which are truly strokes, are misinterpreted by trained physicians. So it's something which is negligible. It's a pretty reasonable number. So what can we do once we have a blood clot, occluding a vessel? What can we do? There's a technology which is called endovascular therapy, which has been introduced a couple of years ago, which is highly effective. So if you use this, you have a catheter being pulled up through your groin all the way up into the artery of the brain. You screw through the blood clot more or less, and then you remove mechanically this blood clot to reopen that vessel. That's called endovascular therapy. Extremely efficient, 80 to 90% reopening rate if you are in the right center at the right time. And that is exactly the problem. Because if you can do this, if you are close to one of these endovascular treatment centers, you're great. If you're not, you might be doomed. Only 5% of all stroke patients here in the United States actually are being treated with this therapy, endovascular treatment. Only 5%. Now, of course, not all stroke patients qualify for that, but the ones who do qualify, only 5% actually get treated with this. So the major limitation we see is, how do we get there? So we have a treatment which is highly efficient, but it can only be performed in so-called endovascular treatment centers, such as Comprehensive Stroke Center, which is being used synonymous. So where are these centers? So the major challenge we see, as mentioned, it's always about time. So the major challenge is, how do we access the proper stroke care in time? That's the important thing. And if you look at the landscape of medical facilities here in the United States, we're looking at about 6,120 hospitals US-wide. Now, only 5% do have these EVT centers. Obviously not very much, very limited. 24% of all the hospitals we have in the United States do have a primary stroke center. That means they have stroke-educated personnel knowing how to treat a stroke, not with a catheter, not with the EVT technology, but they have the stroke competency. Now, the rest of it, over 70%, does not have stroke expertise in-house. Quite concerning, because if I'm not in one of these areas, it might be something which tells me, okay, I have a problem if I really should suffer from a stroke, if I end up in this 71% group. Let's take a look at the emergency departments. There's a lot overlap, obviously, because most of the emergency departments are part of hospitals. But we have in the United States about 5,553 emergency departments. Stroke expertise means whether it's physically by a stroke neurologist or a stroke consultant or telemedicine is available in 44% of the emergency departments. The majority has no stroke experience or access to stroke experience at all. So if I have a stroke, it's almost like, throwing a dice, whether I end up with proper care or not. So the transfer rate to EVT centers is about 60%. So if you have a large vessel occlusion stroke, which is the most severe form of a stroke, you have a really good chance to come to the center where this endovascular treatment can be deployed, 60%. In 40% of these cases, though, you have to be transferred. It means you go with your symptoms to a hospital which is nearest to you. You will be assessed. Yes, this might look like a stroke, but we cannot treat it. We transfer this patient to an endovascular treatment center. So that's in 40% of all the cases, that's the case. So again, time comes into play. So what does it mean, actually, if time is really so much of essence? So you have learned already that every minute a treatment is delayed, you lose about 2 million brain cells. Beyond, you lose 4 days of disability-free life. That means a life which after the stroke has been resolved, where you can participate in your social life, in your family life, work life. That's meant by disability-free life. So, and every minute you don't start or you delay a treatment, you accrue $1,000, más o menos, more or less, in stroke-related costs. So let's take another look at the transfer rate. As I've mentioned, you have stroke symptoms, you go to a center, you will be assessed. Decision is being made, is this really a stroke or not? First of all, if it's a stroke, now we have to transfer this patient. So how long does that actually take, and how much does this really impact stroke care? I would like to get a little bit into this study which was released last year by the group of Kathy and et al. Neurointerventional surgical procedures. And it actually looked at the travel time and the impact of the travel time on, or whether or not a certain treatment, like endovascular treatment, can be deployed or not. So let me guide you a little bit through this table. So nearest is meant the primary stroke center. So this is the really well-established, highly educated stroke specialized hospital, but which cannot perform an endovascular treatment. Bypass is exactly that. That's the EVT center. Stroke expertise is there 24/7, and an endovascular treatment can be provided in this center. That's bypass. Transfer means you go to a hospital XYZ. From that hospital, you will be transferred to a stroke specialized center. So let's take a look at the runtime. So if you are, let's say, in San Diego, and you suffer from a stroke, the access to the next primary stroke center is very quickly. Within 10 minutes, the paramedics will drop you off there. Great, you're in a good shape. If you want to go directly to an EVT center, which is then obviously decided by the paramedic, it takes about 20 minutes. Still really good. Now, if you are in a non-stroke specialized hospital and you are there being assessed, diagnostics is being done, the decision is being made that you have to be transferred to a center. Now, all this group, and this is the vast majority, as we've seen, of hospitals we know, it's been in this study broken up into 3 different groups. 60, 90 minutes, 120 minutes, door in, door out. That means the time it takes until the patient is being admitted to the emergency department, is being assessed, diagnostics is being done, and door out means now the patient is being transferred to a comprehensive or EVT center. That's what it means. So let's take a look at the numbers. So urban, we're fine. But even if you are in an urban area like San Diego, when you go to a hospital which is not stroke specialized, it takes about 60 minutes until you're being completely assessed and decision is being made. Now it takes another 27.5 minutes until you're being transferred to the actual EVT center. So total of 1 hour and 30 minutes, more or less, it takes until you have been admitted to the first medical facility and until you arrive at the facility where you should be. Okay, so that's urban. So let's take a look at suburban. That's where I'm living. I'm not living in San Diego City. I'm not living right in the center. I'm living in the suburban. So for me, it would take about 24 minutes until the paramedics are dropping me off at the nearest hospital. So that's great. It takes about 50 minutes until they would make the decision and drop me off at an EVT center. It takes 120 minutes, means 2 hours. If I would go to my next community hospital, they do the workup, do the diagnostics, makes a decision, call the paramedics, the transfer, whatever, and I receive in the EVT center 120 minutes. So keep in mind what we've learned earlier, that stroke is all about time. Okay, so if we pick this example, and you've seen in the slide before, the related to costs and disability-free lives, this is what it would mean. So in this 120 minutes, we lose 228 million brain cells. we lose 480 days, almost 16 months of disability-free life, and we accrue $120,000 in stroke-related costs. And that's just to arrive in the center where you should be. So therapy has not kicked in yet. You just arrived at the center. Just to give you a perception of how much time is really of essence. Now, what is being used to diagnose a stroke? I told you it's a clinical decision, it's a clinical diagnosis. So I look at the symptoms and I make my assumptions. So this could be a stroke. But normally then there's a diagnostic tool, like an imaging tool, which confirms or disconfirms what I think it is. Okay? So the standard of care today is either CT or MRI. So brain perfusion means blood supply to the brain. If it's an occlusion like we have just seen, blood perfusion supply is limited at a certain area where the stroke occurs. But that's true for a lot of brain disease, but stroke is what we're talking about today. So that's what's happening. So you measure brain perfusion, okay? So the standard is CT and MRI, but you need contrast media to do that, because if you don't, you might get a picture like this without contrast, where you see already this dark spot. That's the stroke. That's very obvious, but in a lot of cases, you do not see this because of the timing. Or you want to make this, is it really worthwhile transporting this patient to an EVT center to see how much success I could reach if I reopen this vessel? Because if it's too long, we have nothing but dead tissue, and you can reopen, but you don't achieve anything in terms of clinical improvement. So you need contrast media. If you need contrast media, it is limited because it comes with a not insignificant side effects to the patient. So you cannot repeat this test, let's say, every couple of minutes or twice a day. It's not working this way. It's because they're either radioactive or they're otherwise harming the body system. So the CT and MRI methods actually are not necessarily cheap. So I think a CT generally costs about $6,000 to $8,000. With contrast media, it gets up to 10 and above. One thing which is important, the CT or the MRI obviously cannot be done at the bedside. So you have to transport the patient, whatever condition he or she is in, to the scanner. And the third one is, because of the cost and because of the contrast media, it's not accessible everywhere. Again, if we are here in San Diego, we are oversupplied with CT and MRI scanners. If you live in a rural area, let's say Alpine and beyond, situation is very different. So it's not accessible everywhere where it should be. Okay, so I would like to make a quick pit stop and ask some questions. You don't have to participate. You can just nod or just shake your head. Whatever you do is fine. So, and please, beg my pardon. Do you all know what an electrocardiogram is? You do. Okay, just nodding is enough. Okay. So, who of you have received an EKG somewhere in your life? More or less all of you. Did you receive the EKG because you had symptoms of a heart attack? No? Okay. Did you receive an EKG because, let's say, you went to your general practitioner, get your yearly physical, and he just made an EKG because, ... just because, right? Not because you had symptoms of a heart attack. Okay. So the EKG is what we know today is so-called point of care diagnostics. So it means you get an EKG not only because you might suffer from a disease like a heart attack or anything else. You get an EKG just to see if the heart is doing good. So the 12-lead EKG, which is a little bit advanced version of the EKG, was first introduced 1942 by Mr. Goldberg. The 12-lead EKG, if you go to the website of the American Heart Association, is now the recommended, guideline-supported standard of care for all paramedics to treat patients who might suffer from a heart attack. Okay, so it's established, it's everywhere. It's standard of care. So may I ask you how many approaches or devices we have to, as a point of care diagnostic, to diagnose a stroke or to screen a stroke. Do you know how many there are? 0. Yeah, exactly. There's nothing. So if you think about this last question, do you know if stroke we know now is the second common cause of death worldwide? Do you know what the first common cause of death worldwide is? Any idea?
Heart.
It's a myocardial infarction. So the heart attack is the #1 killer worldwide. So for the #1 killer worldwide, we have everything we need. We have guidelines. We have a diagnostic screening tool, which is being used globally everywhere, whether you need it or just to check if you're okay. What do we have for stroke, which is the second common cause of death? The #1 reason for long-term disability, 0. We have no screening tool, no device whatsoever to see if somebody really suffers from a stroke. It's pure, again, if you look at the guidelines from the American Stroke Association, with the same club, the guidelines to assess paramedics stroke pre-hospitally, for example, it's pure clinical assessment, no tool. So now we continue with our stroke story. So if we would, picture such a device, what should this device do? It should allow us to make a quick diagnosis, whether it's a stroke, yes or no, immediately. Whether it's pre-hospital, whether it's a paramedic, whether it's in the hospital, in the ED, on the ward, at your general practitioner, in a nursing home, wherever you think there might be a stroke happening right now, you should have a device which you could use right away to confirm or disconfirm your clinical assessment. That's #1. If you have that tool and you have a confirmation, now the next step is you don't go to the next hospital, which might be not stroke specialized. You go directly to the comprehensive stroke center where optimal care can be provided. That would be the outcome of it. And if that's there, if the patients are in that hospital much, much quicker, now you can provide all the optimal therapy like mechanical thrombectomy right away. That's how the optimal screening tool should look like. And actually, in fact, if I would like to propose that in terms of early stroke detection, this device should be used in any medical care institution, like the ones I've mentioned, where no stroke expertise is available. So if you have that tool, you can provide early confirmation of what you see clinically, ideally with a portable device you can carry around with you, battery powered, very easy to use. This would be the requirements. If you do so, you can route patients directly to the stroke centers where optimal care can be provided much, much earlier, not 120 minutes later, right? And if you have accomplished that, then you increase the number of patients who are eligible and who can receive optimal stroke care like mechanical thrombectomy. Now, and then the last point is easy to say. If you have an earlier treatment, because we know 2 million brain cells die every minute, the earlier you treat a patient, the better the clinical outcome is, and the more you save in stroke-related costs all along. So that brings us, and I finish here, to our device, which we have developed in our company, which we think fulfills that unmet need. And I'm done with my presentation. Thank you very much.
Questions?
So is there any factors that determines the early stroke detection? The biological factors for detecting the early stroke detection, and how is your instrument will help in detecting those factors?
Could you repeat the question, please?
Is there any factors in the biological system that determine the early stroke, and how is your instrument helpful in detecting those factors?
First question, there are no biomarkers for stroke. No biomarkers which are accepted and which are proven to be valid. It's not like you have a myocardial infarction where you can check and test for MBB, for proteins, specific proteins. There's no such thing for stroke, not yet. People are working on it, but nothing is established, so it's not available. The way we try to do this is by simply measuring the blood flow. So very similar very similar to CT or MRI. We use a tracer, which we inject into the peripheral vein. And this tracer will behave differently in areas which are not perfused, which don't get any kind of blood. So it's very, very similar to CT and MRI technologies. So by that, comparing right to left, again, very similar to an EKG. We don't make an image of the brain. That's what CT and MRI is for. But we get a readout similar to an EKG, which says there's something wrong on the right side, on the left side of the brain, in that vessel territory or in that territory. That's what a device does.
Other questions?
That it can be like equipped in the paramedics vehicle. So while the patient is getting sent to the ambulance, they can send they can lead to the lab and send it to the hospital, and they can do like early diagnosis, but possibly early detection.
Yeah, so the device sizes today are 20 by 20 by 24 centimeters. So it's a little box, weighs about 1.2, 1.3 kilograms, runs on 8 AA batteries, conventional batteries. So the answer is yes, you can take it everywhere. It has all wireless connectivity tools, so you can send data right away if you want to. So that's already built in.
I'm a vascular surgeon. My name's Devin Zerkowski, and I deal with ischemia a lot myself. Not in the brain, though. Your plan is to deploy this in hospitals. Do you have a plan to give this to pre-hospital care providers as well? And how are you going to do that?
Thanks for the question. So the ultimate intention was to do exactly that, to provide this tool for pre-hospital stroke care. Being a neurologist, I never understood why that, and that's why this whole idea came up, and that's why we worked on it. The only reason why we don't deploy it yet in the pre-hospital scenario, where it's by far the largest medical need, is purely because of the economics behind. There's today at least, there's no reasonable reimbursement structure to bring this into the pre-hospital environment right away. Now, if I look at the last 10 years we spent on this device, and somebody in parallel would have thought about a really genius idea how to reimburse, we probably would be there right now, but we aren't. And if you look at this story, the history of the 12-lead EKG, it was very similar, because the 12-lead EKG was established in the hospital first, took years until it got accepted, became the point of care diagnosis, and then it was moved out to the pre-hospital center. So it might be something different for what we see. But if somebody comes up with a genius idea how to reimburse, we would be there today. Yeah.
I have a question.
Yes.
In terms of accuracy and precision versus the MRI based methods today.
So from the data we have studied about 350 patients, mostly in Germany, some here in the United States. We are about to prepare for our FDA trial. What we have seen so far is sensitivity rates, depending on the patient population, between 90 and 95% with our device. To detect, yes, again, it's not a diagnostic tool which says, yes, that's the stroke. It's a device which tells you there's something wrong with the perfusion, with the blood supply. Similar to the EKG. The EKG doesn't tell you it's a myocardial infarction. The EKG tells you there's something wrong with the electrical conduction in the heart muscle, and you make the interpretation as a medical trained personnel. The same with our device. So you see, device gives you information there's something wrong with the perfusion, let's say in the right hemisphere. So if your symptoms on the left side, you see that's conclusive, makes sense, because it's always on the other side. So that's how it works.
And the final question.
Great presentation. I was going to say, next time I move, I need to make sure that I am in very close to the center. If I'm moving my mom and my parents. So thank you for the background. And the question I have is, there are a lot of handheld ultrasound devices right now that's affordable for medication reason for the diagnosis. What are your thoughts on it? You might have to cover it in a situation.
Well, it's very straightforward. All the devices you're referring to are imaging devices, all of them. So they come with a lot of technology, which is nice because you would like to see an image because you are used to look at images. But it comes with complexity in terms of technology and with pricing. So what we wanted to provide is a tool which is very, very cost efficient. So that buying or leasing this device is not a burden. So we got rid of the imaging part because we knew that's where the costs are. And we were using these signal tracers to actually do the diagnostic test.
All right, thank you so much.